discussing. Murmur by definition is anything which is either it's a relatively prolonged audible vibration, and that's how it changes from the heart sounds. Heart sounds are always short and they're very precise. So are clicks and snaps. They are very short, precise sounds. Whereas whenever we discuss about murmur, it's more prolonged than these things. But what is very important about murmur is the way we describe it and way we, way we explain a murmur. So the first and foremost thing about murmur is description in relation to cardiac cycle. That's very important. That means a murmur could be either systolic, diastolic, or it could be a continuous murmur. Now, this looks extremely simple, no? I mean, at this point of your career, you might be thinking, will I make these kind of mistake? Will we call a systolic, diastolic, or a diastolic, systolic? But, believe me when I say that most common mistake which is done in murmur is confusing systole to diastole and diastole to systole. It's a very common mistake, especially in the beginning, but it's extremely common mistake. So we should have a foolproof way of telling that murmur is either systolic or diastolic. I will come to that in a short while, and then I'll just go back to the previous slide. Yes, okay. Then the loudness or the intensity of murmur. Now, to describe the intensity of murmur, that's something which we spend a lot of time. We keep talking about murmur being grade 3, grade 4, and things like that. But that's not that important, because whatever be the grade of murmur, it does not really speak about the severity. Especially in diastolic murmur, it does have some role. Louder diastolic murmurs are more severe lesion, but it's not true with systolic murmurs at all. For example, all of you know the classical example of VSD. Smaller the VSD, larger the murmur. So most of the time, when you are concentrating on a systolic event, the intensity does not matter. Hence, too much emphasis on intensity doesn't help. Now, the next quality which we actually describe is the pitch of murmur. Now, what is a pitch? It becomes very difficult for people to understand exactly about the pitch of the murmur, and people do get confused about pitch of murmur. The one of my favorite example is when you hear a murmur, it's more like your friend's motorcycle. I keep telling it in almost all sessions where I take that. When your friend's motorcycle, when it comes, or whether it's a car or motorcycle, when you hear the sound, you know that this is the sound of your friend's car or friend's vehicle. But is it possible for you to tell whether it's high pitch, low pitch, or is it possible to categorize? It's probably not possible for you to categorize it into a specific name or specific sound, but you always pick it up. So that means when you're describing a murmur, it's very important for you to befriend your murmur. That means you would have, once you see say 100 cases, you know what you are dealing with. A simple example I can give you is a VSD and a MR. Description wise, both of them match the same. Both are pansystolic, both are high pitch, and both could have whatever grade. But when you auscultate, once you have done a sizable number, once you know what it is, you really know that this is MR or this is VSD. How do you do that? That MR is a pure high pitch. It's a sound which is extremely pure, and as you auscultate, you get that one sound, and that's what makes you believe that is MR. Whereas when you auscultate a VSD, although the description almost matches, you realize there are lots of harshness to that, or lots of eddy current. So more harsher the murmur, the lower is the pitch. So a VSD actually is a mid-pitch murmur. It's not really a high-pitch murmur. The more softer it is and more pure it is higher the pitch. That's probably opposite of what we normally think, but that's how it is. It's also important to understand the configuration of the murmur. What do we mean by configuration? Configuration is the ability to analyze that this murmur it's not going up and down. It's not like a diamond shaped or not like a crescent or like an AR that it is coming down. It's more to realize that it's all the same. For example, when you listen to MR, the murmur is all the same from beginning to end. It always goes in one particular direction, and that is what we call as configuration. Duration, again, extremely important. When we say duration, first is to classify it into systolic or diastolic. And in systolic, diastolic, again to tell whether it is in the first half, the second half, the third half, and to understand where it is, whether it's starting with this sound or starting with the other sound. Although all, when you first examine a patient, and if you're not really into cardiology or medicine, these things sound purely theoretical. But let me remind you, when any one of us started to actually measure a blood pressure, those sounds what you get, how many of you really got it in the first time? I'm sure the answer is less than 5% of people. But right now, after so many years of practice, moment you keep it, you know it is there and you are able to distinguish all the sounds. So even when you do it with murmur, it's very important for you to do this, to befriend it, to have heard enough, to have believed in it. Unless you believe in it, it's not revealed to you. So it's very important to understand and concentrate, and not just think that your professor is bluffing or professor is just making up things. As you do more and more, you realize that people are actually following it. The next little important thing is the direction or radiation. At the end of it, I'm just going to summarize this one slide little bit, because this is something which is extremely important. Radiation. Now, there are two terms which are used in murmur. One is radiation, second is conduction. So there is also little controversy here. Your examiner could be using one to describe the other, and you could have been taught in a different way. So be little flexible here. In case if your examiner is asking you for one more explanation, be little flexible, because there is definitely two school of thought when we describe about radiation of the murmur. In simple words, radiation is a selective propagation. The way I describe and way most of my teachers have described and most places we describe is a selective propagation. To me, radiation means second best. For example, a MR murmur radius to axilla and back. It's a selective propagation, and it actually means that it is second best. That is radiation. What's conduction? Conduction actually means, if you say take apex and take equal point, 5 centimeter to axilla, 5 centimeter medial. If you take an equal distance, then both the sounds, if they are heard the same, then it is conduction. So let me repeat it. Conduction is like from one point, heat conducts, it spreads all around. That is conduction. Radiation is selective propagation. That means if you have MR murmur, it is selectively propagated to axilla. And if you have a AR murmur, it is AS murmur, there is a selective propagation to carotid. For example, a murmur which is best in the right second space, the next best is carotid, then it is radiation. But the same distance you measure somewhere down, and if uh, that is not as best as the site or the upper side, then it is if it is equally best, it is called conduction. If it is not best, it is radiation. So radiation is a selective propagation. That means murmurs second best after this is radiation. So just to summarize what we did now is timing is extremely important, loudness not so important, pitch is an important factor, but it may not be what you believe in, what you think as high pitch, low pitch, could go up and down. Remember, harsher the murmur, lower the pitch, more pure quality, higher the pitch. Configuration is exactly how it is across the group, and radiation is second best. It's a selective propagation, or it is second best. Now, there are other factors which do affect, which we should understand, that in an obese person or an emphysema person, where there's more distance between the heart and the chest wall, the murmur could vary. Hence, most of the time in cardiology, when you compare, the comparison is within. It's never how, like when you compare a P2, you compare it to A2. When you compare S2, you compare it to S1. Most comparisons are in the same person and you do not compare it across. Now, how important is murmur? So let me tell you in the beginning itself, murmur is not the most important thing in cardiology. This may be disappointing because most of you probably took murmur cardiology for murmur, but it is not the most important thing. Most important thing in cardiology is actually palpation. Inspection, palpation combined is extremely important. Hence, you have to make a hemodynamic diagnosis based on your inspection and palpation. Hemodynamic diagnosis. By hemodynamic, we mean that we tell that there is cardiomegaly, there is no cardiomegaly, there is volume overload, there is pressure overload. Those hemodynamic measurements are made mainly on palpation. Maybe someday we could discuss palpation if Sudhakar is okay with that. But today we'll stick to auscultation. Whenever we discuss auscultation, especially murmur, to me it's more like an investigation. That means I am doing it to confirm my diagnosis and I do not want to be confused by what I find. That means I already know what I'm trying to look for, and that's what we do. Now, all of us know the sites of murmur, the best sites of murmur, and you know, murmur is not exactly where the valve is, but it is more where the blood flows after the valve. That's where the murmur is. So, apex classically is being the mitral area, and tricuspid, the lower right sternum, left sternum, the lower part is tricuspid area. Then you have right second space, which is aortic area. Aortic valve is not there, but the aortic sounds are there. Left second space is pulmonary area, and then you have additional herbs area. So this is something which all of you are aware. A point to note, which I should tell you right now, is that imagine there is a cardiomegaly and apex is in seventh intercostal space. It's very much possible in DCM and lots of other conditions. So most of the time you get MR murmur and S there, but the mitral stenosis murmur is usually, there are two things which are usually in original apical area. One is the MS murmur. So be very careful. You may not get it in the displaced apex. You might actually get it in fifth intercostal space where normally you would find the apex. Second is click. Click again is very like the opening snap. Opening snap is very unlikely to be in the dilated apex, and it's more likely to be in the position where it is likely to be there. Now, how do you describe murmur? We went into that. I'm just going to recapitulate little quickly, especially for people who joined little late. Position, we already discussed position in cardiac cycle. I'm going to spend a minute here to understand what does this mean. Systole or diastole is very important. Now, how do we do that? You're already auscultating. Do you want to time it with S1, S2, or what do you want to time it with? I wouldn't time it with S1, S2 because there are too many sounds. Even when the heart rate is 60, if you get two or three heart sounds, then there are already 180 events. And it is something which is very difficult for any normal person to do. So for me to tell systolic, diastolic, the most important thing is I time it with apex or I time it with carotid. And what do we do with that? Only two things: with apex or with carotid, or without apex or without carotid. Do not try before and after. That's not going to happen. It's a cycle. Whatever is before will come after. So it's just a cycle, and hence it is very important for you to tell with apex, without apex. Anything with the apex is systolic, anything without apex is diastolic. And there's also one more simple trick. If you're confused, it's likely diastolic because systolic comes with, you're unlikely to be confused. You will pick up a systole. If you're getting confused with the timing, and if you're otherwise not a confused person, then it's very likely that you're dealing with a diastolic. Okay. So just remember, keep a stat on the apex. The apex also moves with the stat, or keep your hand next to apex and you are keeping somewhere. Just think one thing in your mind: with or without. That's all you need. Anything with is systolic, anything without is diastolic. If it is confusing, it's very, very likely that you're dealing with diastolic. That's the key thing, and this is the cardinal error which most people do in cardiology, especially in the beginning. So it's something which people make mistake, except that you could be making this mistake and then identify. The next thing is site of murmur. We already discussed that is the site of the maximum intensity, which could be for mitral murmur apex, a tricuspid murmur. It could be in the lower tricuspid area. That's how it is. Intensity of murmur, as I told you, not very important. Although too much time and too much effort is spent, not very important, especially for systolic murmur. For example, MR, whether it's mild MR, moderate MR, severe MR, since the gradient between LV and LA is almost the same, the murmur would be similar intensity. Both could be very loud, or in presence of LV dysfunction, actually most severe MR could actually be soft. So it's very difficult to diagnose the severity of the lesion based on intensity, but it's important. Quality pitch, remember Friend's motorcycle. That means if you have 100 times you have auscultated MR, next MR you get it properly. VSD, you get it properly. Radiation and conduction, we already discussed. Second best. Apical murmur, keep the steth 5 centimeter into apex, into the axilla. You can also keep it 5 centimeter into the lower sternum. If both are equal, it's conduction. That means all around any area. You can even keep it down towards abdomen. If it is equal everywhere, then it's conduction, like heat conducting. But you find that axilla is very good, but the medial part, when you come, it's not that good. This is definitely a radiation. That's how you distinguish. Equidistance from different area. If one of the point is better than other points, it's radiation. If all points look almost the same, that is conduction. Very important at the end to look for dynamic changes. If time permits, I will be discussing some of them. Otherwise, let's see how to take it forward. So I hope there are no doubts in any of the this one, and I see the chat empty right now, so I don't have to answer any questions right now. If you have any questions, please type it in the chat. I may not be able to answer them right now, but I'll make it a point to take up these questions at the end. The description of murmur, something which you already know, we just covered it. What else we need to know? Okay, this is the next is this position of murmur in cardiac cycle. Early systolic, there are very few examples of early systolic. If I have to be precise, there is probably 3 of them which are early systolic. So the important 3 are: one is acute MR, because now the LA and LV pressure becomes more. VSD, especially muscular one, because it could close it. And a low pressure TR. So whenever the pressure equalizes or the aperture itself closes, you get early systolic murmur. Where do you get mid systolic? Variety of example. All of you do know this, and I don't have to describe this. Almost all of you do know the mid systolic. Do not call it ejection systolic, because ejection depicts a mechanism, and sometimes we are not sure of the mechanism till we make the diagnosis. When you describe a murmur, all you know that it is systolic and it is in the middle of the systole, so it's mid systolic. Pan or holosystolic, where the gradient remains same like MRTR and VSD. Late systolic occurs in MVP or TVP, where the valve, the problem comes later as the valve bulges. You get a late systolic, mid to late systolic murmur. Again, we have diastolic murmur, which is early diastolic, like in AR, or sometimes high pressure PR, but not a low pressure PR. Mid diastolic, classical MS and the flow murmur about in the tricuspid and mitral area. Pre-systolic, we do not call it late diastolic, we call it pre-systolic, before systole, like in Austin Flint murmur, like it in MS murmur with the accentuation. So these are some of the things which we do. But remember, cardiac position, systole or diastole is very important. So I'm going to repeat this here. Time it with either apex or carotid, and preferably not with S1, S2, with and without. Systolic is with and diastolic is without. When you do that, half the problems are anyway solved straight away. Now, grading. This is what I was telling you. Diastolic, Levine, and Freeman are the one who grade. That I will really not go into this. You need to use it in all your cases. See, one more thing about when you describe a murmur is, you cannot allow your examiner to scoop out the answer. Answer should actually be there all the time. You can't allow them to scoop out. So, if you're you need to describe murmur. For example, if I have to describe a MS murmur, have to tell that the site of the murmur, the duration of the murmur, the intensity of the murmur, the pitch of the murmur, and additional features. If I stop at mid-diastolic murmur and if the examiner asks where and then I answer where, then is it grade 2, grade 3? You know what I'm trying to say here. So it becomes extremely difficult and you think you have answered 5 questions, whereas you are actually answering one question in bits and pieces and you don't get marks and people tend to get irritated. The way you finish your murmur tells the examiner that you know your stuff, and it's very important and it's something which is extremely standard. So make sure grading is part of it. Diastolic stop at 4, systolic go at 6. But as I said, it's more fun to do that, but it doesn't add a value addition in diagnosis. But to be honest, most diastolic murmur, the severe, the higher the grade, they're very likely to be severe because after all, loudness actually comes from the pressure difference between the two chamber. In a diastolic condition, higher pressure difference almost always means that there is more gradient. May not be true for all systolic condition, like for example LVLA or RVRA, RVLV. It may not be true at all. The gradient is almost always there, and the murmur sometimes can be inversely related to intensity or severity, like in VSD. Grading is important, but not fully so. Now, what does quality of and pitch differs? Pitch depends on flow, and pitch also depends on pressure gradient. So whenever you say low pitch, they are actually likely to be from the lower pressure gradient. But these murmurs could actually be more harsher, something which is more superficial, like pericardial rub is much harsher than a heart sound. Why? It's actually low pitch. So do not confuse harshness with pitch. Okay, that's the error which people make. So harsher things are actually lower pitch. For example, MR. I'm sure all of you have examined MR and all of you have actually examined high pressure TR. When you realize that the pitch actually in these is it's a pure high quality, like a high tone, and the pitch is actually they're actually high pitch, whereas MS is more like somebody walking on the, it's more rustling as or rumbling or rustling as we put it. It's actually lower pitch. So do not confuse. So pitch is little different. Pericardial rub, low pitch. S1, high pitch. AR, high pitch. MR, high pitch. So high pitch is something which is more pure and it's more this. Just remember this. Just remember MR as high pitch, because I'm sure there's nobody in this audience who has not auscultated MR or AR, and you know how it is. You feel the pureness of the sound when you auscultate these things. Whereas MS is like rustling. It's more irritating, to be honest, and they are considered low pitch. Now there is also what we call as medium pitch, and the one more point to be remembered: whenever you have a high pitch sound, you do not have thrill at all. Like for example, MR hardly ever has thrill. AR, which is also high pitch, although diastolic, it is still high pitch because the pressure difference between aorta and LV is huge, and it is probably independent of severity of AR. Like a milder AR will have more severe difference between aorta and LV, and that in that way it is a high pitch sound. So high pitch means there is actually higher pressure difference between the two chamber. So it's a higher pitch sound, hence it is more pure, hardly ever has thrill. Whereas MS, which is low pitch, almost always has thrill. Pericardial rub has thrill. S2, S3, which are low pitch, are palpable. So lower the pitch are more palpable than higher pitch things. So here, there are 2 points I would like to make. One is what is medium pitch. Medium pitch are condition like aortic stenosis and VSD, where there are lots of eddy currents along with the pure high pitch. So these are the things which are making them more palpable and making the murmur more harsher and not blowing. But most of the time in exam, you do not have to use medium pitch unless the examiner asks you whether it is a medium pitch. So you always stick to the round low pitch and high pitch. And you do not have to use the term medium pitch unless somebody asks you to do. But remember, that's where AS or VSD differ from MR or AR. Now, when you look back, you realize MR, are very pure, whereas VSD and AS, although they are also traditionally classified as a high pitch, there is an element of intermediate pitch which makes the murmur more palpable and also gives that extra, rustiness to their murmur. So remember, there are three pitch, but you could stick to just low pitch and high pitch. How do you distinguish? This is something which is very important, and I think that should be the crux of today's class, where we say how to distinguish a high pitch murmur from a low pitch murmur. The key here is I could put the other way. The biggest mistake people do is intermediate auscultation. By intermediate auscultation, what I mean is you're not using bell as a bell or a diaphragm as a diaphragm. You're using it in between. So do not do that. Either a steth should be used as a diaphragm or it should be used as a bell, but never as in between. So you take a steth, if you're using a diaphragm, let's use only diaphragm and keep it very hard, just press it as if you should get that rung, or you could use the bell and press it very hard. Both this will act same. If you press the bell very hard, it is also equivalent to a diaphragm, and that is when you get high pitch. If you put say apex, there is both MSMR, you press it hard, that's where you hear S1 S2 and you hear a pansystolic murmur of MR. You keep it very light, you keep it just as if it is barely touching, then you don't hear these things. You hear the rumbling MDM of MS. You press it hard, the MS murmur completely disappears. The low pitch part is completely eliminated, and you only get the high pitch component. So please learn to do that and do it in all your cases. I'm going to repeat this part just so that everybody understands. No intermediate auscultation. No intermediate auscultation. You could use bell or diaphragm, but anything which is pressed hard is a diaphragm. Anything which kept light is a bell. If I have to do, I won't turn it. I will take my stethoscope, which typically now don't have bells at all. So we would keep it very light. At this point, I'm going to get more low pitch things, but I'm also going to keep higher pitch things. That means I will hear S3, I will hear MDM. And when I press hard, all that disappears. That's how you pick up S3. That's how you pick up MDM. It disappears. You don't hear it at all. And now what you hear is only a pansystolic murmur or S1, S2. Again, you do it very light and you see that reappearance of a low pitch things. So please understand this and please follow this. And if you do that, you will have absolutely no problem in picking up all this. But most people just keep the step the way they want to keep, and then you're picking up both high pitch and low pitch, and you're confused. The ability in cardiology to make it, the person who is the best person has 2-3 qualities. One, they will make sure it is systolic, diastolic. They will make sure you're using bell or diaphragm. That means you want to focus on low pitch or high pitch. The third ability is the ability to cut the cardiac cycle into multiple division and to understand that to concentrate near S1 or concentrate near S2. That's what we do. When you concentrate near S1, you get some other some findings, and when you concentrate near S2, you get some other different findings. So I hope everybody is. I'm going to look at the chat again, because if somebody has a question, yes. TR and TS murmur and high pitch MDM. Yes, I'm going to answer that. Dr. Arjun and Dr. Santosh, I'm going to do that. But let's stick with low and high pitch, and also remember that there is what we know as an intermediate pitch. Okay. So let me go to the next part of the talk: conduction versus radiation. Again, no confusion here. Radiation means second best. Best apex, second best axilla. Conduction is a sound all over. So radiation versus conduction. Now classification and type of murmur, I'm going to uh, go to this, and I'm going to go little into all this. Now heart again has right and left structure, so whatever comes in right typically comes in the left and the vice versa. So it's enough to learn some things and understand some of these things. I'm sure I can upload these slides and you could go through all of these later. I think if you're seeing the screen, when you're looking at mid systolic murmur, as we discussed, we are not going to use the term ejection systolic because that means there is a ejection and we don't see that. We only see the timing, so stick to mid systolic murmur. So if you're in a mid systolic murmur, it could be left sided or it could be right sided. Typically, right-sided severe stenosis cross A2 because A2 comes much earlier up to P2, whereas left-sided are definitely much before, and you get respiratory variation in the right side. When you say holosystolic, that means they are complete and they reach the other side. So right-sided has to go till P2, and early systolic is more near S1 and late systolic is more near S2. This is what I was exactly telling you. The third component of auscultation is ability to split the timing near S1 and near S2. Because you can't do a lot. Because see, even with 60, if you're looking at 4 events in a cardiac cycle, you're going to have 250 events. And I am sure most people cannot in a minute, and 250 events in a minute, I don't think so most people can just comprehend that kind of event. So it's very important for you to split it: systole, diastole, high pitch, low pitch, S1, S2. Once you do this, most of the time half the problems are solved. But also remember, the most common errors are these. The most common error is when you diagnose the other one instead of this, and then you miss the train and you are in a different train, and the whole diagnosis actually goes haywire. Let's discuss some common things. Obviously, I'm not going to go to each and everything, and it's just not possible to finish everything. And I'm sure Sudhakar will not allow us to, go on about this. So let's stick to what we know as a mid-systolic murmur. So we know that mid-systolic murmur is the most common murmur. Both physiological and pathological murmurs are mid-systolic. Now, it could happen in 5 different conditions. One, it can happen in any outflow like AS or PS, or what we call as RVOTO, LVOTO. It can also occur in, which includes valvular, subvalvular, supravalvular on both right side and left side. It could also occur in dilated trunks. When PA dilates in hypertension, in aorta dilates in aneurysm, you could get a so-called mid-systolic murmur. Normal physiological flow acceleration like anemia, thyrotoxic, small children, it could occur. It could also occur as an innocent murmur, especially in a younger person. Very rarely, some form of MR also could be mid-systolic. So whenever you have a mid-systolic murmur, it's actually very difficult because it could be any of these conditions. Now, all of you know why is it why ejection murmurs are mid-systolic. I'm sure you understand there is isovolumetric contraction, no flow, isovolumetric relaxation, no flow. So you have the flow only during ejection, and that's where most of these murmurs are found. Now, aortic stenosis is something I think we should discuss, and some 2-3 of them. So, in aortic stenosis, you have a crescendo decrescendo murmur. Okay, you have a ejection murmur, you have a crescendo. That means you can feel the murmur going up and then coming down. Now, this is very important. It's typically a ejection murmur, but since we are auscultating, it's a mid-systolic murmur. It's also, as you auscultate more and more aortic stenosis or pulmonary stenosis, you realize that you're able to distinguish this from MR. That's what you realize. Why? Because the quality of murmur itself is totally different. The timing of murmur is also totally different. You can get S1 clearly, you can get S2 clearly. So you're going to get these two, but the trick is to find out that MR, if I have to draw, is like this, a straight line. It's uniform throughout. Here you don't see the uniformity. You see a harshness. You also see it peak and this. I agree with you that initially it looks all too much theory and too much made up. But as you do it, examine more and more, you realize that it's all true. So believe in this and look at it. That's the key point here. Murmur went way before the diastole because of the, so it will end way before A to P2. But if there is a, not in AS, but in PS, it can overshoot AC sometimes. So depending on the severity is also important. See, the most important in AS, for example, if you want to describe AS, or if you want to describe, tell the examiner that I'm going to describe a severe AS and not mild to moderate AS. The trick is not to tell about it's loud, it's 4, it's 5. Yes, it could be 4, 5, but that doesn't matter. What matters is the length of murmur. It's a mid-systolic murmur. A longer murmur, severe is the stenosis. So a moderate to severe AS will always have a long murmur. The second thing what it will have is a delayed peak. It's going to be long and it's going to go peak later. So you look at this example here, one here, you realize that it is getting delayed peak. Same time, there are other features which are very important. The same time, the patient is going to have a apicocarotid delay. To tell that there is AS, remember this point, to tell that there is AS, there has to be apicocarotid delay. Echo can pick up AS even otherwise, but clinically, if you have to do it, it's a sign of presence. That's something which you should understand. Almost all disease have one point which tells disease is present and one point which tells disease is severe. Please understand it and on your own with your friends discuss. What is that point for AS? To tell presence, you should have apicocarotid delay. To tell severe, you need to have a prolonged murmur with delayed peaking, and also same time the S2 could actually become paradoxical, indicating the sign of paradoxical actually because the sign of A to P2 is different. So paradoxical is very important, and since the class is not about that, I'm going to skip it right now and let's see. Now the second point is important. I'm sure all of you know AS. AS will have a mid-systolic murmur, more severe the AS, longer the murmur, more delayed the peak. Please know that there are other features. Now what is Gala-Verdin phenomena and how do you distinguish from MR? This is probably a standard question. One more important point in exam is, see, examiner is not going to fight with you. They are not going to sit with you when you say there is AR. They are not going to sit, oh, there is no AR, I don't hear the murmur. That's very unlikely to happen. It's more about the way you answer the question, and they go more trying to trick you in your own answers. So, you need to have what is known as an internal consistency. It's not made up finding, it's about being very consistent with what you do. That means whenever you have a doubt of some finding not matching your diagnosis, please go back, reconfirm, and weigh your options. Like for example, I would put my money in palpation and not in auscultation, because I know that there are more chances of error in auscultation and less chances of error in palpation. So you need to decide if there is a contradiction between an auscultatory and a palpatory finding, stick more to palpation. Now, AS and Gala-Verdin, remember Gala-Verdin does not occur in all AS. It only occurs in a calcific AS. That means you are going to talk about Gala-Verdin murmur in a above person who is 60 to 65-year-old where there is a sclerodegenerative AS, and you think that the murmur is actually in such a person, you are you already know there is AS. Now there is only one question: is there additional MR? It's not actually distinguishing AS with MR. AS is there because you find out AS. There is apicocarotid delay, there is carotid thrill, there is there is a mid-systolic murmur in aortic area. But because of the calcium, there is a selective propagation of high pitched waves. Because I told you AS is predominantly mid pitch, so you get a high pitch quality. You also get a lot of irritating sound, but the musical sound which you find gets traveled to apex. In apex, when you just keep a step, you will feel, oh, I'm hearing a MR. Why? Because it looks like MR. There is no low pitch. But how do we distinguish? If there is only AS and no MR, See, the murmur is still mid-systolic. You hear S1 properly, you hear S2 properly. So it is still mid-systolic. That's the first and important point. Okay. When there is Gelaberdin and when you hear it in the apex, the base of the heart is fine. When you hear Gelaberdin in apex, you realize that the murmur is looks very pure, but it's not hollow or pansystolic. It is still mid-systolic. S1 and S2 are very clearly heard, whereas MR buries them both. If you have AF, since the AS is actually outflow murmur, there is beat to beat variation, whereas MR there is no variation. If you have ectopic, then there is beat to beat variation. In MR, there is no variation. So I hope all of you understood it. So if not, I think you can write it in the chat if you have any doubt. If you have understood it, I'm going to go next. So how do you mistake? Galabardine occurs only when there is a high pitch. It occurs only in calcific AS, doesn't occur in all AS, and there is a selective propagation. But since it is still a AS murmur, it is mid-systolic. It is going to vary with PVC or AF. S1, S2 is clearly heard. These are the differences different from the dynamic auscultation. As such, these are the few. So it should not be difficult to distinguish as long as you are careful, but it's not MR versus AR. There is AS which is already there, and you are trying to find out is there additional MS. Okay, MR, sorry. So anything which increases the contractility will increase AS murmur, but will not do to MR murmur. Now, another very interesting point in AS is whether it is valvular, supravalvular, or subvalvular. Valvular is I'm sure this is something which you should know whenever you are dealing with LVOT. First of all, you make a diagnosis of LVOT. Some things are common. The common things are mid-systolic murmur, depending on severity, delayed peaking, a slow, the paradoxical split, pressure overloaded apex. These are common. Then, if it is supravalvular, that means the murmur is best in the right first intercostal space. The person is likely to have a jerky right carotid and conda effect. More than 10 millimeter blood pressure difference in right and left is actually significant, but a conda effect or a conda phenomenon, you call it conda phenomenon only if the difference is more than 30 millimeter. So jerky right carotid, higher right hand pulse, slow left carotid, lower left pulse, and a murmur best in right intercostal space, hardly any AR is a sign of supravalvular. The person could actually have a Alpine phases, which is found in 50% of the people. It helps. What do you do with valvular AS? It's best in proper aortic area, that is right second intercostal space. You could have a click, but click is found in only younger people, but click localizes it into the valve. So you could have a click, murmur radius to both carotids are very low. You could have plus minus AR. Now, what is subvalvular? We are discussing about subvalvular fixed. That means we are not discussing about HOCM here. We are discussing about subvalvular fixed, like a membrane or a tunnel. There is a murmur. It destroys the aortic wall. So the murmur is best in Erb's area or left third intercostal space. Radiation to carotid, very rare. Radiation to the clicks, again very rare. AR is maximum. You get maximum AR with the fixed subvalvular. Why? Because the aortic valve gets destroyed because of the jet hitting. You get maximum AR. Otherwise, the murmur quality nature between all these three are almost the same. But these are the differences which we should know. Okay, these are the differences which we should definitely know. Now, coming to HOCM, HOCM is very dynamic. You get a murmur very similar to the AS, but the difference is that you have a jerky right carotids, and you could have bisperance kind of pulse. So it's usually not confused with the AS. One very important point is the right-sided. If you have a murmur in the left second third intercostal space, like a high sternal parasternal area, is the most difficult, because there are 10 different conditions which would present the same, and then You could have this difference. What are the other causes of mid-systolic? You could also have it in ASD across pulmonary valve, because we already discussed any flow like ASD or even VSD can produce a ejection murmur, and condition like AR and sometimes PR, again you can have a ejection murmur. Now PS is something we should do in exam. This is always asked for you. PS AS difference is easy. It's not that tough because the site of murmur is different. PS is one of the loudest murmurs, especially peripheral PS is the loudest known murmur. The reason being it is very anterior and the PS and pulmonary valve is very superficial. It's the most anterior of all the valves, and hence it does produce a murmur which is thicker. And here I've already discussed about mild, moderate, and severe. It's the same rule. There is a ejection murmur. The peaking goes on getting delayed. Longer the murmur overshooting A2 and going up to P2 becomes, it is a severe most PS of PS. But all these PS are with intact ventricular septum. These are not the PS with V at off. That's a different entity altogether. And we are going to probably discuss it somewhere else. Click here is the click. This is the only right-sided event where the click becomes better in expiration rather than inspiration. Click is again a very interesting phenomena, and since we are just discussing, I would just tell about click. Clicks, you have to classify them well. Click is by definition any extra systolic sound is a click, extra systolic sound. But the classification of click are very interesting. You need to classify them as phasic, non-phasic. That means they change with the respiration or no. Ejection, non-ejection. That means they are related to the ejection or no. Then you have to also classify them as vascular and valvular. So click itself is a separate entity. Here we are discussing with the pulmonary valvular click. There is also pulmonary vascular click where the PA is dilated as in PAH or ASD. That click is different. That click is systolic. That click increases with inspiration. But this pulmonary valvular click is best in expiration. How do you pick up a click? Clicks appear like split S1. That's what you should remember. Most of the clicks are very close to S1. So there are 2-3 sounds which are around S1. One is S4, one is S1 itself, one is click. S4 on this side, click the S1 in middle, and click on this side. Now S4, both they all appear like split S1. I'm sure you know how split S2 is. Here also they appear like split one. But if you press the diaphragm hard, make it truly diaphragm, then you will get either S1 and click. And if you keep it loud, light, that's where you get S4. Both S4 and click, they're very close to S1, and that's what you should understand. Okay. This is an interesting slide. I'm sure when I put it in the group, you all please go through that. Whenever there is a TOF, that means there is PS, but there is a TOF. Okay. Key point is S2 is always audible in PS. It may become softer, but it's almost never single in valvular PS. It becomes softer. In TOF, if you say there is S2 split, your chance of passing exam becomes diminutive. I know Parloff gives it, but your chance of actually clearing the exam becomes very, very low unless you're too smart to manage it. Otherwise, it's very low. So S1 is single here, and the murmur is inversely related. Almost always in TOF, there is an early peaking murmur, which is short and which is inversely related to severity of TOF. Severe the TOF, smaller murmur. Whereas when you have intact septum, it's the opposite. More severe the PS, the longer the murmur and more delayed peak. So this cartoon here describes it very well, and please understand. There is also one more click which can happen in TOF, but this click is because of dilated aorta and not because of the valve, as you find in the pulmonary stenosis. So we have discussed AS, we have discussed PS. There are also innocent causes of murmur, which include still murmur and still. You could find in aortic sclerosis. All these murmurs are softer, they are shorter, and they are early peaking, and they are not like the traditional murmur. Now, when you are talking about the pansystolic murmur. I saw some question about pansystolic. Pan and holosystolic murmur are same, so they are not different. And for these to occur, you need to have a constant pressure gradient between the two chambers during systolic. So traditionally, this is MR. This is high pressure TR. This is also VSD, which is non-muscular, could be anywhere. Hypertensive, if you have PDA and AP window and there is pH, so diastolic pressure is same, hence there is no murmur. It occurs in systole. So, but please concentrate on the first three because that is what is more important and more commonly seen. So MR, the murmur, as we discussed, typical MR, the rheumatic MR or most other MRs are actually pansystolic because the valve doesn't close. There is a constant pressure gradient between LV and LA. Intensity is decided by this gradient, so you do not tell the severity based on intensity. Both mild MR and severe MR both could be loud, and severe MR actually could be soft if there is associated LV dysfunction. So loudness does not tell. Timing, again, most MRs are holosystolic except the exception which we are going to deal. They are holosystolic. So these two do not talk about severity. So if you have to diagnose the severity, see again, it's not intensity, it's not duration. In systolic murmur, these two may not be enough. It's not these two which decide the severity. So if you have to diagnose severity of MR, then you need to actually look at MDM and S3. If you have MDM, S3 both, it's likely severe MR. If you have either of them, typically MDM, then it is likely moderate MR. And if you have none of them, that is mild MR. So mild to severe MR, all are pansystolic, all could be loud. So you diagnose MR or no more by actually presence of cardiomegaly, presence of volume overload, LV, presence of S3 and presence of MDM. So this is how you diagnose and not by murmur. And that's why I typically say murmur is not, sound and murmur is not the most important thing. We also discussed that a severe MR could actually, severe acute MR could be early because by the later part, the pressure equalizes. A late systolic can actually come because of MVP, because initially the valve is closed. Later, as LV becomes little smaller, MVP, the real problem in MVP is actually like a door and the room and its door. Here, the door is bigger and the room is smaller, so the valve prolapse on itself, and then it regurgitates, it doesn't close. So any condition where LV becomes small, as LV starts ejecting, the blood goes to aorta, LV becomes small. The valve now is much smaller. The valve is bigger, the orifice is smaller. It starts prolapsing and ejecting. That's why you get a late click and a late murmur in MVP. So it behaves way different from most of other MRs, and hence it has to be discussed separately. Now let's come to TR, which is which is again a very interesting question. Now, whenever we discuss TR, it's also pansystolic. It can mimic MR in very more. When you keep a step, you feel, oh, am I looking at TR or am I looking at MR? So the first thing is you have to distinguish from this and distinguish from what we call as a organic TR or low pressure TR. So when you are discussing with high pressure TR, it's exactly like MR. The way to distinguish inching method. Inching means you keep it in the apex, start inching medially. As you come more and more medial, if the murmur is again constantly decreasing, then it is only MR. There is no TR. As you come medially, murmur goes down, but again it goes up in the medial part. That means there are two different murmur. Then it is TR. So there is MR, there is also TR, but this TR is hypertensive TR. It's only hypertensive TR which mimics MR. That's what you should understand here right away. That means when you keep a stat, it is that pure, it's actually a beautiful murmur, to be honest. If you are anybody is interested in music, it's like a very high pitched sound where it looks very pure and unadulterated sound. That's what you get when you auscultate both high pressure MR and high pressure TR. So how do you distinguish a high pressure and a low pressure TR? That's very important. TR could also have a peripheral sign. I'm sure we don't have a time to discuss all that things, but let's discuss the most important thing. A low pressure TR is not a high pitch murmur because the pressure gradient between RV and RA is lower. So one, there are no signs of pH. That means if I keep a hand, there is no parasternal heave, there is no palpable P2, and even the JVP is not very fancy, although it can be elevated. It's very fancy in a high pressure TR. In low pressure TR, the murmur is actually low pitch. That means it is more like a pericardial rub, and it is early murmur. So it's nothing like a MR murmur which we know. Only high pressure TR is like MR murmur. This is nothing like MR murmur. This is very superficial. This is very scratchy. If at all, it is like pericardial rub. So you understand this needs both bell and diaphragm. It will be heard little better in diaphragm, but not so much in bell. It doesn't disappear. So you get that scratchy superficial sound. So once you hear this low pressure TR, you typically you don't forget it. You remember it almost all the time. So it is an early systolic, a low pitch, superficial, scratchy sound, not a pansystolic MR like sound. It's different. If you find it, it is organic TR. And then there are 6 to 7 causes, which includes rheumatic, but most are, it could be found in Epstein's, it could be found in carcinoid, RVMI. There are some form of RCM. There's a big list of condition, but remember that you need to distinguish between these two. So we have finished the ejection murmur, we have finished the pan murmur. Now let's go to the VSD murmur, which is again a pansystolic murmur. And this is something I think we don't have to discuss much, but this is a mid, you don't have to say it, but in your mind, you should always know this is actually mid frequency. That means that's why I'm getting a thrill. It's not as pure as MR. You get a lot of thrill here and lot of eddy current here, and its murmur intensity could be inversely proportional to the severity. Again, just murmur is not enough. To make a diagnosis of VSD and to identify whether it is severe or no, you need other things. You need to look at cardiomegaly, you need to look at LVS3, LVMDM, flow murmur. You also need to look at the signs of PAH. So that's when you make diagnosis of a VSD. So MVP we already discussed. It is a mismatch between the annulus and the valve. Valve is too big, hence it folds on itself. So whenever there is a problem, it explains. I think this Dr. Vishnu has asked to explain about MVP murmur. Yes, I'm going to do it. So let's understand MVP here. So what are we doing with the MVP? MVP is a mid or late systolic murmur. Why do you get it? Because now the valve has to prolapse. What is the basic problem in MVP? Too big a valve, too small a orifice. So orifice small, valve big, valve folds on itself. It could fold so much that it could actually leak. That's MVP. Whenever it folds, the valve, this becomes the chordae have to pull it, and when it pulls, you get that sound, which is a click. This is a non-ejection because it's not related to ejection. Non-phasic means not related to respiration. A click. So in this case, click, what happens is the initial part LV is full, so the murmur and the click doesn't occur. Towards end, the click occurs and you get a murmur. That's what you get in MVP. Valsalva state 2. I think Valsalva requires a separate. Dynamic auscultation is something I think we should discuss in some other class. I'll talk to Sudhakar about that, and maybe we could have one more class about dynamic auscultation and how things change in dynamic auscultation. How do you distinguish MR from this? What exactly is dynamic auscultation? I think we could do it in one more class. We do have quite a lot. So Sudhakar, can you hear me? Yeah.
Yes, sir. Yes, sir.
Yeah. So
I think we can continue the diastolic and continuous at another class, sir.
Yeah, we can do that. No, Sudhakar, I think that's
Yes, sir.
no? So today,
Yes, sir.
diastolic, continuous, and dynamic auscultation also.
Correct, sir. Correct, sir.
And the distinguishing each of them, we could do it in one more class. Yeah, we have
Yes, sir. Sure, sir.
spent 1 hour. Yeah.
Yes,
Let
sir.
me just see some questions and answer them.
Sure, sir.
Okay.
Sure, sir.
So first question is by Arjun. How about TR and TS murmur? Yes, I think by this time we have answered it. Arjun, TR, there is a high pressure TR and there is a low pressure TR. Low pressure TR is only pericardial rub like murmur. TS is, TS, it's interesting. I think anyway, I'm going to do it in the next class. So TS we can discuss with MS. No. Why is OS high pitch and MDM is medium pitch? Yes, OS is opening of the mitral valve, and it's going to be high pitch because it's the valve which is opening and it's not produced by the sound. So OS is actually it's high pitch. MDM medium pitch because OS is the valve opening. MDM is medium pitch because I think it's a gradient between LV and LA which is lower. Whenever it is lower, it is medium pitch. Dr. Abhinav has asked, is there a difference between pan and hole? No, as far as we are concerned, it's exactly same. Use it wherever you have. I think PPT and slides will be uploaded and Sudhakar will take care of that. And Galavadin high pitch to low pitch murmur, sir. Yeah, Galavadin, now AS murmur, as we discussed, Dr. Vishnu, has two components. AS is typically a medium pitch murmur, although, I don't know whether you heard it before, but remember it's a medium pitch murmur. So whenever you say medium pitch, there is a high pitch component and there is a medium pitch component. That high pitch component typically travels to apex if it is a calcific valve. If it is calcific, it will absorb all the medium pitch, and what gets actually radiated to apex is actually the medium pitch part, high pitch part. Now, whenever it's high pitch, your mind thinks that it is like MR because that's what it is. But the difference is it's still a mid-systolic murmur. There, it's not till a pansystolic, it is mid-systolic. It varies with beat to beat if there is AF or ectopic, and S1 and S2 can be clearly heard. Can you explain about MVP? I think I saw that question in between and probably we did. So lots of requests for PPT. Reynolds number, I think I'll do it in the next class. Why MR does not change with post VPC? MR is a systolic murmur, so the gradient between LA and LV typically does not change with any of this conduction, and it does not change with the ejection because the LV is almost always high pressure. So even if it becomes little more higher with ectopic, it really doesn't matter for MR because LA is always at a low pressure most of the time. But when you talk about aorta is also at 80. And LV is at 120. Imagine your contraction becomes 160, 180, and that remains 80. The murmur changes. So typically, anything which increases the ionotropy of the heart does not increase the AV valve murmur, which is between LA and LV, but will increase the semilunar murmur. So that is the rule. I think it's the same question which is asked by different. No clarity in sound, organic PR and MDM. Yes, this I think Dr. Allen we will discuss in the next class. How to examine epicocarotid delay is it only palpation? Yes, epicocarotid delay is a palpatory finding. Normal delay is 30 millisecond, and you cannot appreciate a 30 millisecond. No